I want to thank everybody for coming. I hope you all had a good lunch. And I hope you're ready for a deep, deep dive of all the sessions we have here at Spotlight Health. This is going to be one of the most interesting and one of the most complicated, talking about the social determinants of health and breaking the cycle of poverty and other factors which prevent people from getting good health care. You're in very, very good hands with my dear friend Courtney Martin. So without further ado, I'll pass you over to Courtney.
Thank you, Andrew. Thank you all so much for being here. As Andrew said, my name is Courtney Martin. I'm a journalist by training. I'm obsessed with storytelling and solutions, so you'll hear both of those things threaded throughout our conversation today. I co-founded something called the Solutions Journalism Network with David Bornstein and Tina Rosenberg of the New York Times. They share a column called Fixes that you may have seen at some point. And our conviction is that journalists have to do as rigorous and compelling a job as covering solutions as they do problems. So I'm really interested in problems, and I'm also really interested in the solutions that can attack them and getting smarter about those. And our group of panelists today are all either reporting on or central to architecting some really incredible solutions. So I could not be more honored to be among them. So social determinants, show of hands, how many of you feel like you really know what that even means? And be honest. Oh, good, all right. Well, you're fancy. You probably have some very elite degrees from fancy schools. I actually had to kind of bone up on exactly what that meant, social determinants. So I'm going to define it for the few of you who didn't know what it meant, or maybe you're just the honest ones. We'll see. There has been increasing recognition over the last 30 years that the global burden of disease and the health inequities that are found in all countries arise in large part from the conditions in which people are born, grow, live, work, and age, right? This is not unintuitive. This is probably intuitive to many of us, but oftentimes we see in kind of these movement moments that if we can name something, and I think that's really what social determinants is about naming something that's rather intuitive to all of us. Of course it matters where you live, work, et cetera. But these conditions are referred to as social determinants of health, a term encompassing the social, economic, political, cultural, and environmental determinants of health. It's particularly important right now, other than obviously the US context in which we're talking about healthcare a lot. It's important in terms of this global moment of globalization and this sort of naive hope that many of us had that rising tides would lift all boats. Well, in fact, all of the inequities, social, political, economic, environmental, are affecting health, right? It's not about fixing just the healthcare system. It's about all of the important stuff surrounding the healthcare system. So that's what we're going to dig into today. A quick roadmap for you. We've got 90 minutes. It's called a deep dive, as you probably know. We're going to do a Q&A right now that's sort of an introductory piece with one of the foremost experts in this country on social determinants, Dr. Garth Graham. And then we're going to have a conversation with two incredible women about the magical power of relationships, because both of them are thinking a lot about how relationships are at the center of social determinants of health. Then we're going to go and talk about the panel. We're going to do a panel on building whole systems around social determinants of health. So intro, relationships, systems. Then I'm going to get this whole amazing crew back up here, and we're going to do Q&A. So be thinking about your questions, your comments, as long as they are short and concise, but hopefully your questions for this incredible group. So without further ado, let's jump in. I am going to embarrass this man who just had to drive all the way from Denver because it was too windy to land. So he's our hero for actually being here. Look at that. You already got applause.
Okay, well, now it's worth it. All right. Well, now the drive is worth it.
It is a beautiful drive, let's all be honest. Okay, so Garth Graham is a cardiologist, the president of the Aetna Foundation, and an associate professor of medicine at University of Connecticut School of Medicine. Previously, he was Deputy Assistant Secretary in the U.S. Department of Health and Human Services, where he led the Office of Minority Health. He's widely recognized researcher, writer, and editor on health disparities. So we're so lucky to be with you. Tell us, how should we be thinking about social determinants? I gave a little intro, but how do you explain it to people who haven't thought about it much before?
Sure, and it's something, as you just alluded to, that I've devoted both my whole personal life and career to in terms of understanding this issue. Certainly from my role as director of the Office of Minority Health in the prior administration, as well as my role now as president of the Aetna Foundation. So two interesting pieces of data I'll throw out to you. So one is a study that Chris Murray's group just published in JAMA not too long ago, a couple of months ago, looking at the differences in life expectancy. So what they showed was a 20-year difference in life expectancy between counties within the United States. And what they basically showed there in that study was that the majority of those differences, if not all of those differences, were driven by this concept of social determinants of health. So let me give you another piece of data.
And wait, 20-year difference.
20, oh, but
that's a big
that's
number.
A big difference.
Let's not all slide over that 20-year difference.
20-year difference. But let me give you a more granular example. So the city of Boston, I was in Boston for a number of years where I trained. If you go from some zip codes in Roxbury, you can get a life expectancy of about 58, 59 years. And if you go on the red line, that's a little train, and you go up to Back Bay, you go up to a life expectancy for about 90 years. So that's a 30-year difference in life expectancy. That's like going from 1915, which is what our average age of life expectancy was as a country back in the 1910s, 1912, 1913, to 2015. So I like to say you can go 100 years just by getting on the red line. And why that's important, because the majority of that, if not all of that, is driven by things that occur outside of the doctor's office.
Right.
So these things that we term social determinants of health. So housing, transportation, environment, jobs, all of these things that account for how people live their lives. And quite frankly, that's why we use that terminology that your zip code matters more than your genetic code. And there's tons of data that have backed that up over the years. And so when we look at kind of this evolving principle of social determinants of health, what we're really understanding is the vast majority of things that are going to drive how long any of us live, from those who live in poor, underserved communities to the folks in this room, is going to be where you live. And when you think about that, your home, your community, all of those things define the kind of life you live, like I said before, just how long you live. So it's really important for us as a country right now, as we're wrapping our heads around, how do we provide care, not just to one particular segment, but for all of us across the country, to understand just how important these things are. Because I think, quite frankly, this is the defining principle in healthcare, and certainly a defining moment for us as we address a lot of these challenges in healthcare.
That's really helpful. And, we're, 10 minutes in, and I'm already feeling this sense of, this is such an important framing, but it's also a deeply overwhelming framing in a sense, because you feel like, well, here I thought the healthcare system was broken, which it is, and now I hear it's not even about the healthcare system, it's like everything, which I know to be true, but then there is this sense of sort of overwhelm, like, okay, well, if everything about that zip code, like all of these systems and structures are broken, like where do you start? How do you help people not feel like this is too overwhelming to take on? And
so that's where we kind of use the term addressable determinants of health. So we know that there are addressable determinants of health. So we know that within this construct, there are things that we can do that can improve health outcomes. So for instance, if you look at the impact of education, we know that there's a 9-year difference in life expectancy, whether you graduate high school or not. So that's an addressable determinant of health. If we know that we can get folks within local communities to improve their graduation rates, then that will allow those individuals to live a longer life. And so understanding and kind of piecing apart all of these different factors that drive these outcomes and taking it one bit at a time gives us a better understanding of the kinds of things we can do. And I'll give you a more kind of concrete, two more concrete examples. And so, for instance, we're funding this thing called the Healthier Cities and Counties Challenge. And as part of this, there are all these communities, 50 communities across the country, working on these issues of social determinants of health. And so, for instance, in Kansas City, they're doing this amazing program where they're treating violence as if it was a clinical disease. So what does that mean? So I'm a clinician, and so when I see a patient, I think of risk factors. And then I think of if I address these risk factors early, that I can improve their outcomes. And so they're looking at how do you de-escalate a situation where it goes from just a simple conflict and teaching people those kind of conflict resolution techniques so that they can, it doesn't boil over into an actual frank fight or in fact even ultimately a homicide. And so using some of those evidence-based approaches. And so understanding that there are things we can do if we utilize the evidence appropriately that can actually impact these outcomes is particularly important.
Okay, so it's like identifying these leverage points.
That's right.
And then really focusing on if we shift this, then there's all of these counter effects that are going to help the health, even though health was not the thing,
That's exactly
graduation rate or whatever. So are there any really surprising leverage points? You mentioned high school graduation. Is there anything else we would be surprised to learn as a good leverage?
So I think, I'm a doctor, so you'd think that everything I would tell you is about things that occur in a doctor's office. But quite frankly, as I alluded to before, I think the vast majority of people's health outcomes are driven by everything that occurs outside of the office. And so there's a group down in Florida, part of the Florida International University, and they've brought medical students along with social workers, along with allied health professionals into people's homes to address some of these different leveraging points. And what they've shown is that if you allow people to not only engage again in their own decisions around their own health care, but in decisions about how to get a better job, decisions about how to address the actual living situation they live in terms of the actual environment that they live in, that you can again extend both the quality and the length of their life. So I would say education is one key factor. Job and socioeconomic status is another key important factor, but also the safety of housing is another very key important factor that when you put these all together can actually allow us to address these social determinants of health.
Very interesting. Now, you have, as we're talking about, a lot of fancy degrees, and you've had some incredibly important job titles.
There are some fanciness associated.
But you also come of your interest in this in a pretty non-fancy way, right? How has your own life led you to be interested in social determinants?
Sure. So I always kind of have to sometimes when I tell this story, try not to get a little bit too emotional.
We are all about emotion
Thank
here
you.
at Spotlight Health.
Thank you, friends. Thank you, friends. So when we first came to the United States, I came from Jamaica, and we moved first into transitional housing, and then we got housing in this near a community called Opelika, Florida, which is an interesting part of South Florida, which I love. And when we first moved into our home, I always had a little trouble breathing. Every now and then.
How old were you?
This was when I was around 10, 11.
Okay.
So I always had a little trouble breathing. And then one day I was chasing after my older sister. I was chasing after her. Then all of a sudden the world started to get slowly darker and darker and darker and darker. The next thing I remember, I was waking up and there was a really large gentleman and he was pressing on my chest. He was going crazy. Oh my gosh. And then I woke and a couple of things went through my mind. One is, please stop pressing on my chest because that hurts. And the second was, why aren't you doing this to my sister? And then the third, and I think that's inspired a lot of my life, is I looked beyond kind of the gentleman in the room and I looked over and there was my mother. And she just had this raw look of fear on her face. And I think about my own kids, right? And how if anything happens, if my kid has a cough, he's off to the pediatrician. Really, that's what happens in our house. And so I think about the fear she had in that moment when she saw her own child facing a life and death situation. And so for me, that's driven a lot about this concept of social determinants of health. And because quite frankly, what had happened was I had a reaction to the mold that was in our home. This new home that we moved in. And so I understand both kind of from a personal level and then moving up to a professional level, just how vital these things are. So I almost lost my life to the concept that we're talking about here today. But more importantly, what I do know is that my mother, in terms of just her own emotions, I think that's always driven how she's approached us as children. So it's very, very real. It's real for a lot of folks in communities across this country, and it's certainly very real for me.
Thank you for sharing that. And now you're in the position of being a grant maker.
I am.
Having just heard that story, I'm thinking, I want to hear a little bit about how you think about grant making. How do you see if an organization really is true to the social determinants of health model?
Yep.
But also I'm wondering is your mom still alive?
She is.
How has she influenced your grant making? Do you carry her kind of spirit, her way of addressing in your grant making?
That is such an interesting question. My mother always thought
I didn't tell him I was going to ask that one, so he's like, damn it.
My mother always thought that nothing in life is promised. So talk to my mom sometimes. Anyway, so once, I had trouble speaking when I was growing up. And so we were seeing a speech therapist, and she was saying, well, Lloyd, maybe he can graduate high school, and if you do all these things. And my mother thought to herself, why are you putting that limitation on us? She said, so what do you want? What does your son do? And she was very proud of the speech therapist, very proud of her son, and said, oh, he's going to do all these things. He's going to go, he's going to eventually become a physical therapist. He's going to do all these things. And she said, oh, why can't I do that? And why can't we do that? And so she kind of instilled this concept of education in me and my brothers and sisters. To this day, it drives us. So what does that mean for how we do our work and how I do my work? Nothing in life is inevitable. A lot of folks who live in poorer communities just want the chance, want the ability, and they have the capabilities to change their lives just like we did. And so conceptually, when I approach the strategies that we look for people who have both the evidence and the passion, the drive to do this kind of work. Just like my mom had the evidence, the passion, the drive to push her kids to do better. And with folks who can be able to make that change happen on the ground. And so I didn't think about this, and it's so funny. I never thought about mommy in that way. Did I just say mommy? This is way too personal. This is way too personal. Do not hold that against you. But truthfully, I think that spirit of change and that we can change our situation and that nothing in life is inevitable. And even the social consequences that our grandfathers, great-grandfathers might have been in for a long time, that only gives us an opportunity at this point in time to make change.
That's beautiful. Thank you so much. Do not get up yet because we're going to undo your mic.
Did you know I was going to do
that?
Yes,
but thank you. Let's give Garth a huge round of applause.
That's so funny.
I'm not going to let you. Okay. And now I want to welcome Miriam Zoila Perez and Manmeet Kaur to the stage. They're going to get mic'd quickly. We also have a bonus, which is Nadine Burke-Harris is here. Many of you probably know her work on toxic stress. And you want to sit here and here? Yeah, and when I found out she was here, I was like, you have to come to our panel, and we need to incorporate you into our conversation about the magic of relationships. So she's here, but we will also be hearing from her. So let me introduce you to these incredible women. Miriam Zoila Perez is the gender columnist for Color Lines, which is an online publication that if you have not checked out, you really should. They're doing some of the most cutting-edge reporting on race. And Miriam in particular does a lot around race and health. She was an editor at feministing.com for 4 years, which is where she and I met many, many years ago. You might also know her from her TED Women talk on how racism harms pregnant women, which has now been viewed nearly 1 million times. And she is the author of The Radical Doula Guide, a political primer for full-spectrum pregnancy and childbirth support. So please welcome Miriam. And then to my right, Manmeet Kaur is the founder and executive director of City HealthWorks. In launching City HealthWorks, she sought to apply innovations from developing countries to the US, providing support for individuals and families struggling with chronic diseases in the East Harlem community. She's worked in New York to improve the working conditions of quote-unquote unregulated workers, in India to stabilize the livelihoods of construction laborers at LaborNet, and in South Africa to help HIV-positive individuals create employment. She is also a Barnard alum, which I am too, so I will add that to your bio. Please welcome Manmeet. Okay. So we're going to start over here. Perez, your understanding of the magic of relationships is in part rooted in your role as a doula. How many people in the room know what a doula is? Wow, that's an unusual room, right?
Yeah,
they know everything. I'm going to stump you before this thing is over. But tell us what a doula is and a little bit about how that's formed, how you think about, as I'm terming it, the magic of relationships.
Yeah, for sure. So a doula, it's an ancient Greek word that was adopted in the 70s in the United States to refer to a person who's trained to provide support to people during pregnancy and childbirth. Not a midwife, not an OB/GYN, really kind of a labor coach, a support person. And so I became trained as a doula over 10 years ago now when I was in college. After a failed pre-med trajectory, organic chemistry did me in, which is probably a common experience. Took me on this path toward midwifery, and a midwife said, you know, if you really want to be a midwife, you should consider becoming a doula. So I took a training. It's usually a weekend-long training with some study and other things. And then started my work supporting, at the time, women during their labor and delivery at a public hospital in North Carolina. And I was doing it as a volunteer. And it was a really beautiful experience to get to be invited to participate in that experience with someone. It was a kind of system where I would walk around the labor and delivery ward and ask if they wanted me to stay with them. And most people didn't know what a doula was. And a number of the women I supported were Spanish-speaking immigrant women. I'm Cuban American, and so I speak Spanish. And so I would then spend the rest of their labor and delivery with them. And it's been incredible. And over the years, my work as a doula, I also started supporting women and people having abortions and miscarriages in a public hospital in North Carolina. And that's kind of a new movement of doulas moving away from just labor and delivery to the full spectrum of pregnancy. And it's been incredible for me to see like how much of an impact you can have in simply witnessing someone's experience and kind of holding their hand and encouraging them. And my philosophy as a doula is that I'm not trying to change your experience. I'm just trying to kind of be a supportive person in the room who says whatever's experiencing, whatever you're feeling is exactly right and exactly what you should be feeling. And I don't have any other job in the room. You know, other people are worried about the health of the pregnancy or the baby, or you know, they have a relationship to the mom, or they're a medical provider. But my role is just really there to support you and help you have the best experience you can. And that's actually been pretty transformational for people, even within a few hours of experience with someone. And so it's really transformed the way I think about what these interventions can look like, and that you don't actually need a lot of technology or a lot of anything really particularly expensive or fancy to have an impact on people's lives.
Yeah, and I feel like pulling the thread through from what Garth was saying, in contrast to the overwhelmingness of like we have to fix all of these things in order to fix healthcare, it is so freeing to think maybe one of the things that can fix a lot of this is the simple power of a witnessing relationship, right? There's nothing hugely complicated about doula work, to your point. It's really just being there for another person without an agenda, which is mentoring and all of these other things.
Right. And there's a lot of research actually that shows that just having a person even sitting in the room with you can improve your less interventions, maternal satisfaction improves. There's actually a lot of research supporting the work that doulas do.
That's so great. So Manmeet, I'm new to your model, but I fell in love with it as soon as I started reading about it. It seems so important. And I'm also obsessed with South to North learning, so I'm so excited to talk to you about that aspect. But I was thinking there might be kind of a parallel in the doula sense, because your model, it seems to me, is based on the power of a relationship, and a fairly simple relationship. Like, there are important things about how that relationship has to form, but it's really about empowering and listening. Tell us a little bit about the model.
Sure. So the organization is called City HealthWorks, and we're currently based in Harlem, New York. And the idea is not new. It's actually very old. It's the idea that if you hire someone from the community that they're serving, a community health worker, that they can have a profound effect on health, and in many developing countries, a dramatic effect on morbidity and mortality in places where you have one doctor to 28,000 people in a country like Tanzania. And so I started this after I'm from New York, but I spent a few years working in South Africa and India and then sub-Saharan Africa on workforce development and community health initiatives, and I fell in love with the simplicity of that relationship and just the openness with which people share what's going on, as well as then get the support to connect to the right care at the right time. And I think the relational piece for me is also personal, because I know that growing up in our family, that there were a lot of things that would have been different if my mother and others who were struggling with things had someone who understood what the stigma meant in this community around a certain issue. And I think who we serve is very important to qualify or describe. We're in Harlem currently, but wherever we would go, we would hire people from that community. But we tend to get referrals of patients who have gone through whatever service was available so far in the clinic. And these are not the most complicated patients. They are not actually the 1-2% sickest of our society. It is people who have 1, 2, 3, 4 chronic conditions, but they are in their home still. Majority of them are elderly, and many of them struggle with literacy. Many of them can't speak, or write in their own language, but would not say that to someone or their doctor because it's embarrassing. Or many of them have cognitive impairments or physical limitations. And I think even without those barriers, what I've become really passionate about as a non-clinician who got into this work is that chronic diseases are very complicated.
Yeah.
It's not just that someone is poor and they need more help.
Healthcare was complicated.
But just in the realm of your body and what you need to take care of. I mean, I think what I also am really passionate about is not just about we need to give more services to poor people. It is recognizing as a health system, you give someone a list of 7 medications. How many people in this room are on 1 medication? 1 to 3. How many people in this room are on 3 to 7 medications? So the average number of medications our patients are on is 7.
Wow.
Just think of each medication you've ever had to take and how much you had to, just read those complicated words.
Interacting with one another.
They're interacting with one another. You are, majority of care in low-income neighborhoods is in training clinics, so you're seeing different doctors each time. They're in training, which is, many of them are phenomenal, but there's just a lack of consistency. And if you have a memory challenge, how are you going to be the onus on the patient to know, to be prepared for that meeting, to go home understanding those medications, to go home taking the advice of eat better when you are on $200 or $300 a month of benefits is completely ludicrous. And I think that I'd like to turn the conversation around that it's not just extra support for those who need it most, but there's an absolute missing infrastructure of a layer. We have inpatient care, we have outpatient care. We do not do chronic care. We're very good at reactive care. And so I think it's, what I fell in love with is this power of people who are from, who can relate to you. And I think an example is, a woman who one of our coaches was working with just recently, who I just met, who started her first meet. This is a woman who had...
So you call them coaches?
We call them health coaches.
And they're assigned to one specific person or like a caseload of people? How do you think about their workload?
We get, majority of them are coming to us from the clinic. The doctor's referring them, or a nurse or someone who's saying this one, this person could really benefit from some one-on-one coaching. And then we go meet in their home one-on-one. Depending on what the condition is, if it's asthma, we just meet a small handful of times because it's mostly about seeing what's in the house. If it's diabetes, hypertension, or congestive heart failure, we are doing a bit more, we spend a bit more time because it's more behavioral. And there's a lot of content to understand in terms of the nutrition as well as the medications. And then we're now starting to work with the hospital settings, meeting people at the bedside who have congestive heart failure and coming home with them. To do transitions of care and coaching at home. We do talk to them on the phone as well, but a lot of it is at the beginning in person. And it's very important because it is then people, we ask a lot of questions in the first meeting, as many caseworkers do. But it's usually after that second or third meeting where all this information comes up, where the clinician just didn't know, or many of them were seeing a social worker. And people, I think we don't recognize the degree of stigma or shame people feel when they're talking about these very sensitive parts of their life. Right. Even if it's clear that you can see that someone's living in poverty, it is not easy to talk about.
Oh, absolutely. Yeah. And talk a little bit about, you were just going to mention one story. Can you bring us into like one coach and the person they worked with and how the coaching helped support them?
So this is someone actively going through coaching right now who was seeing a social worker regularly and was going to her visits, but was really struggling to control her blood sugar. And in the very first meeting with Hilda, her health coach, she just started crying and saying, my mother is a good person, but because of her schizophrenia, she is going through my wallet and my personal items every day, so I always have to carry out all my important papers. She won't let me cook at home. She won't let me bring healthy food at home. She's very controlling about when food is made, where it's made, and who's doing it. This is a woman who was a domestic violence survivor who moved in with her mother because she had to leave a violent situation, and she loves her mom. But because of her mom's condition, she's not socially isolated, but it is a difficult situation. So she really needs housing, safe, separate housing. But she also was given a lot of support from the medical team, and I think what I wanted to highlight is, for example, she was given a blood sugar monitor, but no one explained how to use it. She was given a set of medications. They changed at some point, and there was poor communication with the pharmacy. So our coaches spend, I would say, a third of their time just on the phone between the pharmacist, the doctor's office, the specialists, navigating these things. But we also do it after that patient is given the permission to say, please help me with this.
That's huge. And people may have heard this term, but I found it really influential in my thinking, called the cognitive tax of poverty. So the time spent fighting with an insurance company or just trying to understand the right dosage because there was communication, et cetera, is something that many of us who have more resources actually outsource to other people, secretaries, support people to handle, wives, right? People often say, I want another wife in my family to do these things. And actually, poor people spend even more time than those of us with resources doing that because they're in part of these bureaucratic, intractable systems that are often very broken. So even helping that cognitive tax of poverty be a little lighter,
Yes.
I can imagine would free people up to focus on important things.
Exactly.
Yeah. So back to you, Perez. I want to talk a little bit about the sort of frame around racism actually makes people sick. This is part of this TED Talk that you just gave, specifically looking at how maternal mortality among Black women in the American South is incredibly
in all
extreme.
parts of the United States.
In all parts of the United States. So talk a little bit about that, but I especially want you to talk about this sort of dawning realization that is being researched. I mean, it's not a dawning realization for those of us who have experienced it, but the actual research now that racism does make people sick. Right. Can you talk about that a little bit?
Yeah, for sure. And I think I like Garth's frame a lot about like where you live being such a big determiner. And at least when it comes to maternal health, that's a very racialized thing, right? And so it's where you live, but it's also your race. And we even see that the statistics show that even, particularly for African American women, even who are no longer low income, right, who are middle class, the disparities in terms of how healthy they are at the end of their pregnancy and childbirth are even higher. So like middle class Black women versus middle class white women have a higher gap than Black women and white women generally. So it's not just a question of poverty. I think a lot of people assume that, oh, this is about class and about access to services even, and we're finding it's much deeper than that. And that's where it kind of gets to this question about racism, right? Which is something people experience across class levels. So there's a lot of research about the negative impacts of stress on our bodies, right? On our physiology, kind of overloaded nervous systems, all of these things, right? And so there's also research that says discrimination leads to stress, leads to poor health. And so there's a growing body of research that proves that racism actually does make people sick. And when we think racism, oftentimes people think sort of big systemic issues, but what they're actually showing is that the things that we call microaggressions are not actually that micro when we think about the impact on people's health. And so the experience, for example, of being worried that you're going to be stopped by a police officer when you're driving your car, or being concerned about, I don't know, your documentation status while traveling, or even perhaps being treated badly at a store or at a restaurant, at school, at work, all of these little, what we call microaggressions actually add up to really negative impacts on people's health through the ways in which it weathers the nervous system and creates all these different physiological systems. And so that body of research is there. And so for me, when I looked at maternal health and I saw these really horrific statistics like Black women are 3 to 4 times more likely to die during childbirth than white women in the United States. And there are parts of the Deep South where those rates for Black women actually approximate rates in sub-Saharan Africa. And in those same communities, the rates for white women are near zero. Right? So this is a racialized question in the United States. And other women of color groups also do suffer higher rates, but for African American women, it's the biggest disparity. So that's why I focus there. So we actually know, I mean, the research is showing that racism is making people sick. And so when it comes to maternal health, we often look at interventions like, oh, well, these rates must be because they're not getting enough access to care. Well, people are getting access to care. What kind of care are they getting? And I think that gets to the point that you were making. Is that care, is it good? Is it accessible? Is it culturally competent? Is it respectful? Is it low stress? Does it contribute to someone's well-being, or is it actually adding to sort of the challenges that they're already facing? And how does that actually physically result in a baby being born too early? Because the stress of the body is saying, hey, this is not a safe place for this child. So preterm labor is a really huge problem for women of color, particularly African American women. And that leads to things like low birth weight babies and also infant mortality and maternal mortality, right? So we see a cascade. And for me, I mean, I think the focus really has to be on the ways in which racism is impacting people's health in the United States. And the last thing I'll say that sort of proves this point, immigrants, there's something called the immigrant health paradox that some of you might know, right? That when immigrants come to the United States, the longer they are in the United States, the worse their health becomes. So I'm the child of Cuban immigrants who came to the United States. My health is more likely to be worse than my grandparents' health because of this paradox of the United States. So that points to something that says there's something about the US environment and the way in which particularly people of color and immigrants are being treated that is having a negative impact on their health.
So important. And let's move to the solution that you mentioned in this TED Talk and currently is working on a piece for the New York Times about, it's called the JJ Way. Introduce us to Jenny Joseph and tell us a little bit about, there's this one solution, particularly around the maternal mortality piece.
Right. So Jenny Joseph is a Black midwife from the UK. She works in Orlando, Florida, in a town called Winter Garden. And she has a prenatal clinic there. She also has a birth center. But the thing that's really important about her work is that she's developed a program, a prenatal and postnatal care program for low-income women. She calls it her easy access clinic, and that's where she employs the JJ way. And the thing that's amazing about it is that the women, so there's been some studies of her work. So the women that come see her at her clinic, they go give birth at the hospital called Willie Palmer in Orlando. It's the second largest maternity ward in the country. Women who go give birth at that maternity ward also and are in similar demographics. They did a study based on zip code and racial identification. They didn't see Jenny for prenatal care, 3 times more likely to give birth to a low birth weight baby, which is a huge indicator for negative health outcomes for the lifespan. So just the prenatal care model that Jenny's offering has made a huge impact on the women that she serves. So what is it about her model that's so successful? I mean, it's something I'm still kind of grappling with the question of why does this work so well, right? But we know, one of the things we know is that, and sort of the biggest picture I think of what it does is that it provides a buffer to the stress that these women experience in their daily lives, right? So they have an environment at Jenny's clinic where they are well respected, where they walk in the door and access to care is a guarantee. It doesn't matter if they don't have Medicaid. It doesn't matter if they're undocumented. It doesn't matter if they don't have the $50 to pay for the appointment. They're going to get care. And a lot of these women have been rejected by other places that require you to pay up front now because the health department is so low on cash that you can't even get billed later for your services. So you walk in the door and you get seen. You're treated well. You're treated with respect. You're treated kindly. You're treated as someone who can have a healthy birth. You're not treated as someone who's, oh, this person is a risk factor, so they're probably going to have X, Y, and Z. You're treated as someone who can get there. Jenny likes to say chunky babies, right? She's trying to get everybody to have a happy, chunky, healthy baby. And there lots of cute babies have come out of her clinic. And so there's a respect there. And then the other piece I think is really important, and there was a session this morning on people in this room about a brain cancer survivor that talked about this. The women are actually pretty involved in their own care. And it's not a high-tech model. It's actually a little passport card. It's a little yellow card. And they come in, and they take their own weight, and they write down their weight, and they do a pee test. And then the nurse will write down like the blood pressure and things like that. And they carry this card around with them every time their appointment. So it's just one indication of the ways in which they are included in that process of like, here's how you're doing, here's some of the metrics that we're measuring throughout your term. So I mean,
there's also almost a coach
Yeah,
model, right? I mean,
kind of
there's
a
some
coaching
similarities.
feel.
There's
Yeah.
women who will text with the pregnant women.
Exactly,
Hey,
yeah.
how are you feeling? You know, just like a
Right.
friendly sort of support person who
Yeah.
is from the community again.
Yeah, so a
Someone
lot of
rooted
her
in that
staff.
community as
Yeah.
opposed to someone from outside of it.
So yeah, a lot of her staff are also Black women and are also young, and yeah, there's somebody whose job basically it is to be in touch with these women whenever they want to via text. And yeah, they deal with a lot of those issues around health and housing, and you know, so it's like it's not just about their maternity care, right? But it's other things. So Jenny often will be working with people on other things, even though she's not a social worker, right? But that's just the reality for her clinic. She's like, we're going to help you do what you need to do to get to that chunky baby.
Yeah. So we're running out of time, but I do not want to miss Nadine Burke-Harris's wisdom while she's here. She is the nation's foremost expert on toxic stress. I'm going to try again. How many of you know what toxic stress is? You guys,
Yeah.
A+ students in here. But Nadine, will you please explain a little bit briefly about what toxic stress is? And I especially would love to hear you talk about, as you hear these women talking about the magic of relationships, you know, one of the things you all have learned is that one of the best ways to confront toxic stress is through supportive relationships. And so while the toxic stress itself and the levels we're seeing is you know, quite like hard to face, the solution in many ways is about relationships as well, right?
Yeah, that's right. I guess I'll
Yes,
stand up
please
so I can
stand.
see folks, and I will. Everything that you guys just said is supported by what we know about the research and the literature, and this is a place where I'd love to see more of the basic science and the bench science coming to inform what we do. We know that adversity, and particularly childhood adversity, dramatically impacts the development of the brain, the immune system, our hormonal systems, and the way our DNA is read and transcribed. And as an example, there was a study that looked at asthma in kids, and we know that asthma is strongly associated with proximity to a freeway, right? And we've always thought that it's because of the particulates coming from the freeway. But research has shown that individuals with higher adversity that live farther from a freeway have a higher asthma risk than individuals with lower adversity that live closer to a freeway, right?
Wow.
And the reason for this is because the interaction between our environment, right? What we experience every day, and the way that adversity impacts our brain, immune system, hormonal systems, and epigenetic regulation. And the reason I always take the time to say all four of those is because oftentimes we forget about things like the immune system, right? That impact things like asthma and other issues where we see, and ultimately, heart disease, chronic obstructive pulmonary disease, cancer, et cetera. But what we also see is that in a study in our center, our kids, our black and brown kids in Baby Hunters Point in San Francisco, if they had 0 ACEs, only 3 adverse childhood experiences, only 3% of them had learning and behavior problems in school. If they had 4 or more adverse childhood experiences, 51.2% of them had learning and behavior problems in school. The odds ratio was 32.6, right? So when we look at communities that are at high risk, that are very vulnerable, we understand that even in these high-risk communities, there are modifiable risk factors. And I cannot say it enough, one of the most important things that we can do. We know that exposure to adversity, which I would say is one of the biggest modifiable health risk factors that we're seeing today, is handed down from generation to generation. But right now, we have the tools to break that intergenerational transmission. And the way that we do that is by supporting caregivers to be buffers to their children's adversity. We know that nurturant caregiving is an antidote to the physiologic impacts of the activation of the fight or flight response in the body, right? But in order to do that, folks have to be able to regulate their own stress response. And if you are an African, and I will say, listen, we can talk about all these things in the abstract. As a black immigrant woman who came to the United States from Jamaica, go Yardi, I can tell you that when my kids go to the playground and certain people look at us in a certain way, I can feel my fight or flight response being activated. When I see my children threatened in certain situations, I can feel the doses of adrenaline and cortisol being released in my body. Individuals who are, certain individuals, and particularly people in communities of color, people in vulnerable communities, immigrants, are being poisoned with toxic doses of adversity right now in our country. And there is something very important that we can do about that. At the Center for Youth Wellness, which is the organization I started, one thing that we're doing is we're trying to launch a national education campaign about the impact of adverse childhood experiences and toxic stress on health, development, and just about every domain in which a person develops. And the second thing that we're trying to do is that we understand that early detection makes a difference. So I am on a mission to get every pediatrician in the United States of America to screen for early adversity as part of routine primary care health care.
Thank you.
And I will stop there.
You're amazing. Thank you. Okay, so don't get up till you've been unhinged. So obviously we could spend 90 minutes with every one of these individual badasses, and your assignment, since you're all A+ students, is to Google every one of them afterwards, because there's so much more wisdom here. Nadine, I will say, has a book coming out in January on this topic and is really going to launch this public awareness campaign. So for those of you who are interested in supporting, being a part of that, I know there's lots of physicians in the room, please be in touch with her. Check out this incredible organization that this woman has founded. I wish we could have talked way more about, because I'm so excited about it. Check out Perez's TED Talk and her writing forthcoming from the New York Times on the JJ Way. Thank you all so much. Let's have a big round of applause for this crew. Okay, so come on up. My final trio here. I will introduce them as they're getting up to save time. Dr. Martin Burt is founder and CEO of Fundación Paraguaya, a 32-year-old nonprofit organization devoted to the promotion of entrepreneurship and economic self-reliance to eliminate poverty around the world. Why don't you sit here? You're here. And Kevin, will you go here? This is Dr. Burt. He's a pioneer in applying microfinance, microfranchise, youth entrepreneurship, financial literacy, and vocation to address chronic poverty. He's developed one of the world's first financially self-sufficient agricultural and tourism high schools for the rural poor, as well as Poverty Spotlight, a new poverty measurement tool and coaching methodology that assists families to self-diagnose their level of poverty and develop customized plan. This metric is being used in 30 countries. So we're getting into the global portion, and this is the systemic portion, as you might remember from my introduction. This is where we're really talking about systems. So then we have Kevin Washington over here to my right. He is the president and CEO of YMCA in the USA. As I told him, I grew up playing basketball at YMCA, so I am a big fan. A 38-year-old YMCA professional, Kevin Washington is the 14th person and first African-American to lead the Y in the United States. He came to the YMCA of the USA in February 2015 from the YMCA of Greater Boston. He's done incredible things in this YMCA system, including the Hartford YMCA invested more than $60 million to develop or expand 8 facilities and camps. So he's doing on a really large level, thinking about how do we think about social determinants of health in this sort of franchise model, right? Because there are YMCAs all over the country and actually all over the world, which I didn't know prior to researching him. To my left, this beautiful woman and brilliant woman is Neo Tapela, a physician and head of the Non-Communicable Diseases Program in the Botswana Ministry of Health and Wellness. She's also a researcher and policy innovator practiced at strengthening health systems and effective service delivery for non-communicable diseases, such as cancer, diabetes, heart disease, particularly in resource-limited areas in sub-Saharan Africa. She's also an Aspen New Voices Fellow, which if you've been around meeting some of them, you know are the coolest people on this campus right now. So let's jump in. You all bring that we've talked about sort of social determinants of health as a broad issue, as a broad frame. We've talked about the magic of relationships. But how do we do this systemically, right? Because in some ways, we know there are these leverage points that Garth mentioned. We know that the relationship can actually be a fairly simple intervention, creating a nurturing relationship. But to make this system-wide is very complicated. I want to start with you, Dr. Martin Burt, fresh off of his daughter's wedding. He was glowing when he came in. He said, "I'm so happy." You said the key is to learn what the proper level of intervention is without destroying what you are trying to do. That other programs don't encourage people to overcome poverty, they create poverty gaps. You've said we need to create not safety nets, but safety trampolines, which I love. So what do you mean by that? What is a safety trampoline, and how do you create that at a systems level?
Okay, thank you very much, and thank you very much for having me. This is my first time in Aspen, and I'm in love with this place. I've been working in poverty for many years, and searching, like most of us here, what is it that allows people to snap out of poverty? And first of all, we all know that poverty is multidimensional, but what we have grown to learn is that multidimensionality is not only more indicators than income. Multidimensional poverty also has to do with the dimension of bottom up and not only top down. And it also has to do with the dimension of inside out and not only objective hard indicators. So, and in addition to that, the idea of poverty has to do with what is the unit of analysis. The unit of analysis mostly are that governments count poor people one by one. But what if that was wrong and the unit of analysis were not the individual, but the family unit? Then you would not have 1 million poor, but divided by family members, you would have 300,000 family units. Another thing has to do with the perspective. Who's measuring? Is it the government measuring poverty or the poor measuring poverty? Because if you allow the poor to measure poverty, the perspective is completely different. So you can have, for example, let's say financial health. You can be JP Morgan or Wells Fargo measuring financial health, and they will probably measure your financial health as to how many financial products you have. Whereby financial health from the point of view of the head of the family household is, do people get to sleep at night with all the debt that they have? So what we have done is develop a new poverty measurement tool that is a self-diagnosis aimed with technology. I brought my little thing here. And today you can very simply, and we do this in China, in India, Pakistan, Philippines, Mexico, in the United States, in the UK, just allow people to answer, are you red, yellow, or green in income, in health, in environment, in housing, in organization, in participation? Do you vote? Are you registered? Do you have self-esteem? Is there violence? Remember Leo Tolstoy in Anna Karenina? All happy families are alike and each unhappy family is unhappy in their own way. Poverty is like that. So when you have more than one indicator, you find that it is not us, the non-poor, and them, the poor, but you and I may have some reds and some yellows in terms of maybe you have a financial problem and you have a violence problem and your sister has a self-esteem problem, and et cetera. So what we do is we develop not a poverty index where government policy makers and decision makers aggregate data, but we allow the other important decision maker in poverty, which is the mother, to disaggregate data. And instead of having a poverty index, you have a dashboard done by her from her perspective. Poverty, every community in the world knows what it means not to be poor. In Cape Town, the people know what it means not to be poor in a township. In New Orleans, people know what it means not to be poor, and in Beijing. And the key is to ask people, what does it mean for you not to be poor? And then you develop a customized plan done by the family to address their priorities. So you have a different way of looking at poverty, and this is actually a way to challenge the simplistic reduction of people to you are a under $23,000 person. And it also allows you to count your blessings. So the first thing we do, because if you don't count your blessings, they don't count. So the first thing you do is you allow people to know where they're not poor. And then from there, build up. So
will you tell us a story of a moment when you were really surprised by the assessment, like where a poor family, a head of household, taught you something that you were like, oh, I really would never have?
Oh, we have thousands of we're working with poor communities. We're also working within factories, moving away from corporate social responsibility and fair trade and shared value to poverty elimination of all the workforce. We're doing competitions of students who gets their parents out of poverty first. There is nothing more powerful than a 16-year-old girl who wants to win a competition. She will force her family. This is true everywhere, right? And we also have some 13 competitions of the poor getting other poor out of poverty. It's all about activating people. And we're all chameleons, right? We can be passive or we can be active. And so if you treat young people as active, not as vulnerable youth or at-risk youth, but hey, get your family out of poverty and you get to go to the beaches of Brazil for a week. Who do I have to kill, right? So I'll tell you, we were interviewing, one of my social workers was interviewing a lady, and she was doing her poverty stoplight, and she had a grandson. Abuela, grandma, can I talk to you? No, I'm busy, honey, I'm busy. So she was, answering each question, and the kid was, Grandma, can I talk to you? He says, I'm busy, honey. And right when they were coming to the question about family violence, the grandkid says, Grandma, can I talk? Bang! Hits the grandma, gets a pitcher of water, throws it on there. Get out of here. Don't you see I'm talking to the lady? Where were we? And my social worker starts shaking and says, family violence. Oh, no family violence in this family.
Well, here's the limit of the self-assessment, right?
Of course, it's a limit. It also has to do with perspective. Of course it has to do. It's not that an external extractive survey would have captured it better. But what I'm trying to say is that we can eliminate poverty if we change the perspective and we do it from the point of view of the family. We do not have to talk about alleviation or reduction, but elimination. And elimination means nothing else but not having yellows or reds. So we are doing this in many, many countries. The Roma people in southern Spain know what it means not to be poor. The immigrants in Newcastle, northern England, they know what it means not to be poor. So empowering people to be the owners of the poverty and not the government being the owner of the poverty has a great potential. And so we are very encouraged to know that poverty is something that can be eliminated if this perspective and this ownership is activated in any country in the world.
Thank you so much. I want to skip over to Kevin now. So you're in this unique, and how many YMCAs are there across America?
There are 850 YMCAs across America,
Okay.
Independent organizations.
850. And how many of the people in this room have been inside of a YMCA?
How many of you went to camp and swimming at the Y? All right.
So many of us have experienced them physically, but what a lot of us who may have had that kind of experience don't realize is that the YMCA is this, federated network of institutions that, in addition to, coaching basketball and doing swimming, is affecting the health care of so many families at a core level. It's an educational institution. It's a spiritual institution. It has so many levels. So Kevin, help us understand, you're in a unique position because you're doing some pretty radical things, but it's within this large federated system with a long history. So what are the benefits and challenges of that?
Well, first of all, you saw all those hands go up, which is a good thing.
Yeah.
It's quite a few people. The YMCA, as I said, is 850 individual associations. We have 2,700 physical facilities. We're in 10,000 communities, and we have 23 million members. That's the basis of the YMCA of the USA. What's interesting about that, of course, is that it also is a federated organization, meaning each of those YMCAs are separate 501c3s. But they created YUSA because they understood there was an opportunity to effectively use that network for good. And I'll talk a little bit about what that means and where we are in that particular process. As we think about that, I want you to think about this. One, we're able to use that network to scale programs and services over. For instance, we have about 1 million kids today in our resident and day camps. Anybody who's done work with young kids in that regard understands how difficult that is. Two, the YMCAs are set up to respond to local needs. So that local autonomy is important. What's interesting and where we played a role is how do we find that sweet spot between local autonomy and the interdependence of each of us to provide the opportunity to use that scale for good. Mm-hmm. We've had some success in doing work around chronic disease management. The YMCA Diabetes Prevention Program, which some of you may or may be aware of, has served over 100,000 folks across our network to be able to help them improve their particular health around the issue of diabetes prevention. Secondly, working heavily with some of our partners around childhood obesity. Thirdly, we're working with individual organizations around blood pressure management. One of the good things that's come out of that, many of you may or may not be aware, is that just last year, under our previous administration, Department of Health and Human Services has dedicated resources through Medicare and Medicaid to support YMCA diabetes programs so we can get reimbursed from the government for that program. Gives us an opportunity to expand that. And one of the things we think about when we think about that is how it affects vulnerable communities. Because one of the things we're concerned about is access and equity. And this process allows us those particular opportunities. So those challenges are, we're a federated organization, but when we come together, we have the opportunity to use that network to expand exceptional programs for the good of communities in which we work. It really addresses some of the social determinants of health that you heard individuals talk about. Access, environment, community, engagement, and an opportunity for folks to work on their particular issues so they can be better for who they are and what they're doing. So Those are the challenges that we face today as an organization.
One quick follow-up question for you, because one of the things the YMCA does all over the country and all over the world increasingly is fill in gaps, as we talked about. So where there are failing public education systems, where, where there isn't enough extracurricular activity, kids don't have the arts, don't have sports, they're going to Ys, right? Where they're getting, not great clinical care and not hearing about nutrition and not hearing about all these things, they're getting that at the Y. So how do you think about the balance between filling the gaps versus making structural changes in these communities so that those gaps aren't so wide?
So one of the things we can do, as I talked, because of our scale, we can approach it from a public health perspective. We can work with the individual level, we can work at the community level, work at the policy change level. In a couple of instances, so for instance, we're supporting schools in summer learning loss. We're in over 200 communities, working with about 12,000 kids, to ensure that what they learn in the course of the school year, they don't lose in the summer. The results thus far, those youngsters are gaining 2.5 months in reading and 2 months in math. Substantial, because we know they lose on the other side. In addition, with our partners in the Walmart Foundation, we served 19 million meals last year through our programs. That's how we can get our organization, our scale of our organization, moving in a certain direction. So we're filling those gaps that we know are part of society. And we don't do that by ourselves. We do that in partnership with others.
Right. Thank you so much. Okay, I'm turning to the left here, going back to a global context. So Neo, I'm glad we mentioned government, because we got to bring government in here. You've played so many roles. You're a doctor, you're a teacher, you're a mother, as anyone who saw her beautiful daughter last night at the Undaunted event saw. You're a policymaker. You've been inside of government. You've been thinking about this. I wanted to hear from you, what do you wish that your colleagues within government understood about healthcare, and what do you wish your healthcare provider colleagues understood about government?
Thank you. It's really wonderful.
Oh, and she has laryngitis.
Yes.
So if it's hard to hear her, it's not just because she's not speaking up. She's got this thing going on.
I do hope everybody can hear me. So I'd like to mention that I'm coming at this from the perspective of non-communicable diseases, which, this is a discussion about health and development and what the social environment has, what role the social environment has to play in all of that. And my connection to that larger picture is through non-communicable diseases. I want to mention it because oftentimes when people think about non-communicable disease or they think about African countries, they think about HIV, TB, malaria, or maternal and child health. They don't necessarily think about chronic diabetes, hypertension, stroke. So the reality is that these conditions are rising rapidly in Africa, and that the reasons for that is because we are developing, right? Life expectancy is increasing. The reasons for that, particularly for Southern Africa, is that HIV has been prevalent, and while we are succeeding in addressing HIV, HIV is a risk factor for a lot of the non-communicable diseases. I also like to mention non-communicable diseases because the risk factors and the access to treatment for non-communicable diseases are very much related to what we're talking about, right? It is about education, it's about the job you have, and it's about poverty. Evidence now is finding that undernutrition and poverty in childhood result in an increased risk in the non-communicable diseases in the long term. Now, with regards to your question, as a civil servant and as somebody who is in the government of Botswana in the health sector, I think that the first thing that I wish that my colleagues within other ministries really embraced and did a lot more active work upon is related to what Garth mentioned earlier, which is the notion that a patient getting better and healthy, what contributes to that is not what happens in the physician room. Another way of saying it is that health is not made in the health sector. So the way that I often think about it, the most concrete and simple way that I think about it is if a patient doesn't have access to clean water or they don't have regular access to food, they're not going to be able to take their pills, right? And it's not because they don't understand the importance of taking the pills, it's because there are other things that are real, that are contributing to how they're able to engage in their care and get better. So I really do feel that you cannot heal or cure patients without addressing their social environment. Now, with regards to what that means to other sectors, agriculture, education. I think it's already been mentioned pretty wonderfully and articulately. I can give an example that's a concrete example in the work that we've been doing. We're in the final stages of a multi-sectoral national strategy on non-communicable diseases. What that means is I'm head of a program that's in the Ministry of Health, right? Non-communicable diseases are cancers, diabetes, asthma, right? And when you think about it, the risk factors for these include smoking, include not having enough physical exercise, right? Those are things that it's not the Ministry of Health that leads in improving in society. Ministry of Agriculture has a role in making sure that the healthy food options in Botswana, which is a desert country, by the way, so 70% of Botswana is covered by Kalahari Desert. We don't have a lot of rains, and so what is available in terms of fruits and vegetables, you need to innovate and really actively plan towards making that available and accessible, particularly to the most vulnerable in the country. So Ministry of Agriculture has a role there. Ministry of Education has a role in terms of the food that's available, and local government, the food that's available to vulnerable populations, but also physical education and making that a priority in the education system. Right. Those are just some examples. So the strategy that we've developed really brought together, and it required lots of consultation and continued discussion and debate across ministries for their role in making, addressing non-communicable diseases and addressing a huge public health concern in Botswana. And I think this translates to many other countries in Africa. I think with regards to what I would say to my colleagues who are not in the ministry or in government, these are colleagues who are on the ground. Either they are in public facilities as doctors, nurses, community health workers, or civil society, partner organizations. I think there's a need for recognition that there's a role. I truly believe that the government's role is to make sure that opportunities and resources are equitably available to everyone in society. But I think that it doesn't stop individuals, organizations, institutions to innovate within their context. Right. And in fact, if you innovate and agitate in terms of you innovate and you document what you're doing and make sure that it's heard by the government, that really can help speed up what we can do. We talk about evidence-based policy. That's really what we aspire to do. But the reality is there's not enough evidence for the kind of questions we really want answers to. So an example of innovation is, I give an example of Rwanda, which is where I've worked. I had the privilege of working with partners in health and also working closely with the Ministry of Health there. And in Rwanda at the time that I was there, cancer, right? I mentioned cancer because it's one of the most daunting and complex of NCDs, but it is a reality. 250,000 African women die each year from cancer. If you can believe it, that number is more than the number of African women who die from complications of childbirth and pregnancy. So in Rwanda at the time, there was only one oncologist who was based in Kigali. I was working in rural district hospitals, and with partnership of the Ministry of Health and many partners, we were able to set up a cancer treatment program in Butaro with no on-site oncologist. That now it's in 4th year and has treated and provided life-saving cancer treatment to over 4,000 patients. And that's happened because of there wasn't evidence to necessarily say this is how you deliver cancer treatment in a rural poor setting. Right. But it's a conviction that care needs to be available where it's needed. That means where there's disease, right? And it's also the innovation and recognize that you don't need to have oncologists to treat all cancer patients directly. You can innovate by training and task shifting. You can build partnerships where you get mentorship from Boston, from other countries to support delivery of care. So I think that the message always, even though I wear my civil servant hat or member of the government, is that everybody has a role to play, and innovation should help inform what we as the government can do to really expand access to services. I think the last thing maybe to say, you mentioned that I have many roles, hats. I really, as dizzying as it is sometimes because its many roles. I think that I embrace it and I appreciate being a doctor, being a researcher, and being a mother. For me, it's hard. I think it's important to realize that disparities do happen even within countries. I think everybody here, that's been the discussion. But sometimes those inequalities are not in plain sight. They're not evident. Yeah. So for me, being a doctor and continuing to see patients gives me an insight and a groundedness that I might not see in the indicators or the aggregated numbers that we see in government. Being a researcher helps me develop evidence for questions that I have as a policymaker that I don't see being pursued in kind of the conventional research that's taking place. Right. And I think as a mother, it's really sort of the human, as a mother, I feel like I want to live long enough to see my children grown. And I also think a lot about what kind of a world I want my daughter to grow in. I want my son to grow in a world where everybody in society feels like they have equal opportunity to education, to any opportunity that society has to give. And by society, it's not just the country, it's the global society.
Right, absolutely, thank you. You know, Peggy Clark, who we all probably know and love in this room, was quoting Brian Stevenson yesterday talking about his notion that to make real social change, you have to be proximate, right? And I was thinking about that when you're saying as a doctor, you're in the clinic office, you're remembering that one-on-one interaction. Mothers are obviously proximate to the vulnerability of children. And so it feels like one of the tensions here is the proximity of a wise intervention, like being close enough to people that you really understand what you're creating, but making that happen at the systems level. So I want to do rapid fire round because we're running out of time and we want to hear more from these. So quick answers if you guys will indulge me, and then we'll go to the audience. So be thinking about your questions. I want to hear, I have so many questions I want to ask you. What would you pinpoint as most people's biggest misconception about breaking the cycle of poverty after doing this work for over 30 years? What do you see over and over when you're talking to people about this that frustrates you?
Well, what you're mentioning, people, who people? What you are probably, well, government, policymakers, or decision makers at the home. There are two types of actors in poverty. And economic policy that we're saying, it's that the governments are the owners of poverty and are the owners of information. But if information is power, when you have participatory surveys and not extractive surveys, the information stays at home, is owned by the family. We know that if you allow people to define what it means not to be poor, we know that there are people who have overcome many deprivations or all deprivations in South Boston. Not everyone in South Boston is poor in everything. There are mothers who should not have sent all their kids to college but have. And there are other people who should not have such dental care and do. So the problem of poverty in people is that the people up in the policy making think that they know what the families need, and the real people are the the families, and so poverty from the perspective of the poor is a completely different movie than what governments see, and it has nothing to do with Republicans and Democrats or conservatives or it's like Deng Xiaoping. It doesn't matter what color your cat is. It doesn't matter, because there may be some things that the Y can do, and there may be something that the city government can do, and something that the School of Dentistry locally can do. It's when you change the unit of analysis, it's a different picture. The good news, it's a solvable.
Right.
And indicators have to be, when they're done, have to be actionable, understandable, and achievable for the family. So, for example, and I'll finish, infant mortality is a government statistic that is incomprehensible by the mother. It is how many deaths between 0 and first year in 1,000. What can a mother do with that government statistic? The mother can breastfeed, can deal with nutrition, can vaccinate, can feed, can clothe. So if you the same concepts, but you make them achievable, actionable indicators from the point of view of the head of the household, then everything changes. Of course, this does not mean that government is not necessary, but it is a very important idea that poverty will be eliminated when you look at it from the bottom up.
Right. And how do we, and this is not a question because I have to move on, but I'm thinking, how do we create that feedback mechanism by which the government's policy is actually informed by what people in their own homes are saying we need, and this is making a difference, and this is what we feel very rich around, and that kind of. So anyway, keep going over here. We haven't said the word power that much, so we're going to say the word power, and in particular, I'm thinking about many of the people we're talking about are going to some sort of, I'm especially thinking about you, Manmeet, these people going into a clinical setting where there's a power differential, right? And even for me, like a white privileged woman, I leave a doctor's office and I think, I didn't ask 10 questions I meant to ask because I just got intimidated by, like, you're the doctor, you know best, So we can only imagine how race and class and all of these other things are informing the power differential that people feel. The cool thing about the YMCA is I think it has this brand, and we talked about this, to use an advertising word, that people really do have a lot of trust in, who don't have a lot of trust in or haven't felt a lot of shared power from other institutions. So, and you've been kind of undergoing this sort of brand transformation of the Y. Can you talk about that? How did you think about how do we help people trust this institution who are otherwise very justifiably not trustworthy of a lot of institutions?
Well, I think the biggest part about that trust factor is that we are in many of the communities. And many of the people who work at that YMCA are from those communities as well. So there's a natural bond there. And the other piece is, we've been around 170 plus years. Right. So we've built up a level of equity and brand and trust in the things that we do. And some of the things that we've done as an organization, you probably wouldn't recognize. In 1856, we were doing English as a second language in the Cincinnati YMCA in response to the Germans coming to that community and helping them make that transformation to become part of American society. So that brand trust that we built up is very essential to us being involved in the healthcare arena in the way we're in it, because there's this bond and trust, and they're part of the community. It is really the community acting together with those individuals to solve an issue. And it makes we're not this big institution, not that I have anything against big hospitals and anything of that nature, but we're seen as part of the community and an asset in that regard.
Thank you. I'm going to ask my other panelists to come up because we're going to go to the big Q&A, but I'm going to ask Neo a question as they're coming up. I mentioned South to North learning, which is this notion that there are things happening and being innovated in the Global South that can actually be brought to the US as an example, and that we have a lot to learn from those who are pioneering things abroad. And Manmeet has done so much work in the South to North learning space. You have been in Boston and you've been in Botswana. You've seen these things. What do you feel like, and maybe it was in the setting up of the clinic in Rwanda, but are there any specific innovations that you would love to see be applied here in America that you're seeing in either Botswana or Rwanda or other settings?
Sure. I mean, I think there's lots of opportunities for this kind of reverse innovation, if you will. I think one of my first introductions to that is with the Partners in Health model for using community health workers. And I think this really was born out of work in Haiti, where patients with HIV were not taking medicines or were not adherent. But if you really took a deeper look at the reason that is, it could be that the patient is too sick to come to the clinic to pick up the refills. It could be that the patient is socially isolated, right? And so out of that proximity to patients and interrogating what the reasons might be came the innovation and the notion that you could provide social supports through accompaniment, through having a community health worker accompany the patient through the journey of illness, but also through the journey of health and life. And that model has been translated into community health worker program in Boston for marginalized HIV patients. And they do well as a result of that intervention, that innovative intervention. And that model has been translated broadly everywhere that Partners in Health works, which is many countries. I think it was 11 countries last I checked, but I think internationally. I think that so there's many, I mean, and I think I'd mentioned that there are other areas where because of limited resources in low and middle income countries, you're forced to work with fewer resources, but it does make you be creative and find solutions that could be relevant to the US, right? The reality is that the US is resource rich, but the resources are not infinite.
Well, and clearly not spent particularly well, as many other panels at this conference have covered, right?
That's correct.
Yeah.
So examples are task shifting. You don't need specialized services, specialized clinicians to deliver some of the basic and particularly integrated and primary care interventions that are so badly needed and that will help with making patient care more seamless.
Yeah.
Another that I'm particularly interested in and we're working on in Botswana is health information, so electronic medical records, right? So having studied in the US and been in Boston, I was always working with multiple different electronic medical record systems, and if a patient goes from one hospital to the other, which is not far away, totally different system, documentation gets lost, quality of care is compromised because of that. One of the things that we're really working on in Botswana is trying to think of a few important, essential indicators, measures of that will tell us that the health system is delivering care to people and the care is working. So are people with blood pressure getting blood pressure medicines? Not only that, is their blood pressure being controlled 6 months down the line, right? So we are going through an exercise of making sure that we don't have too many indicators, but also that they're standardized throughout the country and potentially in Southern Africa. We have a small grant from the National Institutes of Health that's supporting this effort, but the beauty of it is that you develop a lean set of indicators that are meaningful that you can use to see if the health system is responding to help patients within the region, not just within the country. And I think that notion of lean indicators and prioritizing so that you just have a few of them that are standard across the entire health system, whether it's different hospitals, could help.
So do less and do it better and more consistently.
That's correct.
Okay.
Yeah, I think maybe the other thing I want to mention is there's also south to south innovation and sharing of lessons. So I was fortunate to be in Rwanda and be part of the work there. And there's a lot that we're doing in Botswana that we're translating. You don't have to recreate or learn from mistakes that have already been made. So in Botswana, we are about to introduce national screening for breast cancer for women. And it's really the approach that we have to this introduction has gained a lot from the experience at Butaro. And I think that there's many opportunities to do that, and I think that if we did that, we could really work faster to address non-communicable diseases and do it in a smarter way.
That's wonderful. Okay, so I know you must have a million questions. I believe we have roving mics, right? Yeah, we have one here and probably one over here. Wonderful. So raise your hand, and because we're short on time, concise questions. There's so many smart people in this room, and we want to hear from as many of them as we can, so please.
What a powerhouse panel. Thank you all so much. I'm Matt Winnie. I'm with the University of Colorado, but I was at the American Medical Association for a number of years, and I know there are a lot of folks in the audience who are in the healthcare system, the delivery system, and I'm wondering if you can say anything about the integration of the healthcare delivery, the medical care system, and the rest of the world that affects our healthcare, including things like the YMCA. It's hard sometimes to make referrals from within the medical system to the YMCA to do a diabetes prevention program, for example. And I'm wondering if you have lessons.
Why is it hard? Will you say something about that?
So I can easily make a referral to a rheumatologist. It's in my system.
Right.
There's a box I can check.
Right.
But if I have a patient at risk for diabetes and I want them to go to their local YMCA to have the diabetes prevention program, which is a proven intervention to prevent diabetes, there's no checkbox. I can't make that referral.
Let me say that we are working with that. We're creating an MSO at our organization, Management Service Organization. So far, we've had 10,000 people before that system comes into play that have been referred by doctors for our YMCA diabetes prevention program across the country. We are also working with, so part of our work is being funded through a great partner and a collaborator, Robert Wood Johnson, to help us around this community health integrated process so that we can have people work through their insurance companies. In fact, I won't mention the name of the company, but they have there's a huge airline that have allowed all of the employees to be available, and they're paying for the YMCA Diabetes Prevention Program. So we are seeing this slow transformation to a community integrated process where the YMCA can be, and others can be on the forefront to make those things happen. So there are some good things happening because we're negotiating with insurance companies now for some of the services that we're able to provide.
Best news any of us have heard about airlines in months, am I right?
I won't say who it was.
Is there anyone else on the panel who wants to address this? How can we actually work with clinicians with some of these social determinants?
Yes, I think this concept of integrating the health system with the community has been a challenge for a long time. I think the movement now to value-based purchasing and a lot of these different payment models, even though we're not there, we're still in a very much fee-for-service system, allows people to start to see the value of these other kinds of interventions in terms of the population health that they're going to be measured. So I think that that allows for a broader vision to be had, and I think as the system evolves, we'll hopefully get there.
Just add that, yes. I'd say that clinicians are very hungry, just like you are, to be making those referrals, and that we work really closely with clinicians in developing how we communicate, how we give progress updates. And I think something that really was valued in our experience is that when a referral is made, it's not just into the space and you don't know what happens, but that there's a communication back and forth. And secondly, when providers see that they've referred someone to a YMCA or a program that worked for their patient, they're so much more motivated, and even if it's harder, they'll do it. And so I think the more and more we have these partnerships where clinicians know about these programs and they're referring and they see patients doing well, the more and more you'll see that interaction happening.
That's really smart. Yes, in the back. Oh, sorry, over here. I guess I'm not in control. Sorry, you'll be next.
Sorry. Good afternoon, everyone. My name is Melissa Mercado. I am a behavioral scientist, and I work on children's health issues, specifically youth violence. And I think we can agree today that health doesn't only happen in the healthcare setting, right? It happens in the community, it happens in the family, right? Which means community-based organizations have a big role to play. And faith-based organizations, congregations, are community-based organizations, which are there in the community. They have access to the community. They have the respect of many communities. So I was wondering, I've read the research, the literature. I know there are promotores programs that have worked through churches for diabetes prevention, heart disease, other topic areas, but it's not the trend, right? So I'm wondering, from your perspective, you think we should collaborate more with these congregations beyond large, big faith-based organizations like Salvation Army, the history of the YMCA? How could we work more with congregations, and what's hindering from that happening?
And I'll just expand: congregations, mosques, any kind of religious institution that might be a source of support and probably also a source of trust, getting back to our power dynamic. Like, if this is a place someone already trusts and has this experience. Anyone have work? I mean, obviously the YMCA fits directly into this. Anyone else have thoughts about faith-based interventions? You want to?
We are working with the Catholic Church, particularly in Latin America, because they are interested in trying to capture the family unit perspective, and we have found that families are strengthened when you have a holistic approach, as we were mentioning. So we are working with churches in communities, and also with companies and factories owned by Catholic and Christian leaders who are interested in promoting this poverty elimination perspective. So yeah, it is very, very important development that the church is also very, very interested in moving beyond the traditional components of poverty.
That's great. And Kevin, do you want to weigh in there?
I will tell you, some of our programs, our YMCA Diabetes Prevention Program, our blood pressure self-management program, is not in YMCAs all the time. They're in community centers, they're in churches, they're in barbershops, so that there is an opportunity to have those kind of relationships with others, with the faith-based industry. And quite frankly, a lot of our board members are engaged in that work as well. So there is that community connection.
Maybe I can just add a twist to this as well. We certainly do see the role of community as a big part of not only identifying cases early for cancer, for diabetes, for high blood pressure, but also long-term management for what is a chronic disease. So when, in terms of screenings for blood pressure and glucose, those happen often in churches, at khotla meetings, community meetings in different parts of Botswana. And these are examples that happen in other parts of Africa. I think that, and it's important because, you know, only the sick will go to health facilities, right? So it's important that even the people who are feeling well but have had raging high blood pressure for 5 years will still get evaluated and get picked up. An interesting twist in the discussions that as we've been talking about the multi-sectoral strategy for non-communicable diseases and talking about what civil society can do, what communities can do, in Botswana, community leaders, traditional healers, are individuals who are respected and people still do come to quite significantly when they feel ill. Right. So very similar to what was done with HIV, many countries and many organizations are looking to that group of community resources and leaders to be partners in delivering health services. So part of the approach is educating and sensitizing them what red flag signs are for somebody who's sick with diabetes or who's sick with high blood pressure, and to refer them while still providing their traditional and community role.
Oh, that's wonderful. Okay, we have only time for one more question. I see one over here. I don't know if a mic's over there, or there was this woman in the back. I don't know, someone, oh, way back. I think that's Dr. Willie Parker, am I right?
You're right.
Amazing. All right, Dr. Willie Parker.
Hi. So thank you all for a very exciting panel. And Dr. Graham, the question I have, you cited the statistic of, or at least the finding that a high school education, if someone has a diploma, their lifespan is linked, as their life expectancy is 9 years longer. And I'm wondering, as you do determinant research, when you identify what you think is a determinant, how do you make the decision about whether or not what you're looking at is actually a determinant or a proxy for something else? So when we look at how educational policy is changing and making more heterogeneous the pathway to getting a high school diploma, what is it about having a piece of paper that says you completed 12 years of education that's a determinant for your health, or is that high school diploma a proxy variable for something else?
That's right. In fact, to answer your question quickly, it's your last point. A lot of the research we've done in terms of, the research I was quoting was some stuff that has been published in the literature with other groups. But a lot of the research that my group has done and other groups similar to this have done has been looking at this issue about what are the proxies. And so quite frankly, to answer your question, the high school diploma is really just a proxy for other kinds of things that go along with that. Much like the same way, if we look at what happens with heart disease, where a lot of our research has been done and looking at the outcomes related to socioeconomic status and how long people live from heart disease, all of that has to do with the proxy measures that these do. So your point is well taken that a lot of these are proxy measures. What we do show, though, is that interventions that move even some of these potential proxy measures, so i.e., if you have to get somebody to graduate high school, it allows them and opens up a window and a door of opportunities for all these other kinds of things. So even though they're proxy measures, the interventions do work in terms of how they help to improve life after all.
You know what, we have to end. I want to say to this audience, first of all, thank you for sitting with us. I know 90 minutes is a long time, and you've been a really attentive audience. Take action from this experience, because the social determinants of health is all about action, right? So I would encourage, take 2 actions. One is for yourself. So think about one of the factors that we've talked about today that you feel like you might be in a red light on, where, you know, the red, yellow, green that Dr. Burt was talking about. Think about one of your red light places and think about an action you could take for yourself to improve your own social determinants of health. And then think about the things you heard today. Was there one person who spoke, one organization that you just found riveting? Whatever your resources are, put them towards that organization. It might be money. It might be tweeting about it. It might be sending an email to one of these folks telling them you think their work is incredible and you just want them to know how much you support what they're doing. Whatever it is, please do two things, one for yourself and one for one of these people, so that we can make good on these 90 minutes that we've invested together. Let's have a big round of applause for all of them.